Howard Schubiner is a physician who moved from a career in academia to a medical practice where he faced the challenges of pain like many of us. It was the work of John Sarno that started his journey to approach pain in a different way.
He didn't have all the science and neuroscience to back up what he was saying. And he made a few mistakes along the way, but his general thesis turned out to be right. And he began over years to expand it to other things besides back pain. I went to work with him for a few days, and I came back to our hospital, and I said to my boss, hey, I want to start a little practice.
It became clear to him that getting to know his patients at a deeper level than lab tests and imaging studies was key. As he started to utilize and hone his approach, he started to see some pretty impressive results.
Her headaches completely went away after 17 years of chronic daily headaches. And we see the same thing with back pain and irritable bowel and fibromyalgia. And
it is clear that many healthcare professionals are hesitant to delve into psychology and emotions in their practice. I know I for certainly was. He had some thoughts on this and why it's probably important for us all to incorporate some psychologically informed principles into our practice.
What are you going to do? You're going to just ignore that when you know that's the thing? You could turn off the pain like that and your patient or client would be eternally grateful to you? What are you going to do?
Pain reprocessing therapy was the main focus of his practice, and it was rooted in helping people make sense of their pain and helping them gain skills to move back into the life they wanted.
We reverse that in PRT by helping people be more empowered, less afraid. And sometimes it's hard to do, obviously. How do you make yourself not afraid of pain? Not easy, but gradually over time, we teach them how to change the neural circuits in their brain by...
Physical medicine and rehabilitation clinics have a tendency to be biased towards structural diagnosis. Howard discusses studies that have been published showing that many of the conditions seen in PM&R practices are non-structural or nociplastic in nature.
And if you have 222 people coming to a regular, usual PM&R practice, like all of his partners in his own practice, 95% of them would be diagnosed as having a structural problem.
He also discusses how we need to take our current methods further to develop more comprehensive approaches to better manage pain. More research is on the horizon, and it is hoped that it will continue to help us shed light on better ways to manage and treat pain and help people reclaim their lives.
To take it to the next level beyond the pain education, beyond the CBT and ACT type stuff, to the level of PR. And I'm only saying this because the data, that's what the data is showing us. And we'll follow the data.
In this week's episode, we will talk with Dr. Schubiner about this and much more. Don't forget to check out our community at modernpaincare.com/community to go deep on these topics and more to better help you in your practice. Now, on to the episode.
This is the Modern Pain Podcast with Mark Cardula.
Welcome to the podcast, Howard.
Hey, Mark. Good to see you. Thanks so much for having me.
It's great to have you on. I think there's been a lot of buzz in the research world and really enjoyed reading your work around pain reprocessing therapy. I know you do more than just that. There's other components of your practice that touch upon today, but I think there's been some exciting developments with research of the study that came out in JAMA Psychiatry in 2022. It was a real kind of landmark study that showed we could make some longstanding changes in pain. We've seen some other methods that have been encouraging that have similar yet differing perspectives around kind of dealing with some persistent pain issues. But excited to have you on today. And I was wondering for the audience who may not be aware of you, if you could introduce yourself and then maybe interested in how people get to where they are working with persistent pain and their story, because often it's one laced with frustration of maybe traditional methods of pain. And how did you get to where you are today?
Well, I'm old, Mark. It's kind of a long story. But basically, in my undergraduate years, I had some questions about the medical profession. We had a pamphlet called Billions for Band-Aids back when I was in undergraduate school. Now it's trillions for Band-Aids. But so there was some questioning of how the medical profession was working and whether we were getting to the underlying cause of illnesses or we're just kind of treating symptoms. And anyway, but I spent first 18 years of my career at Wayne State University as a full-time faculty member, and I did research in a variety of different topics, and et cetera. I became a full professor there in 2002, and then I left, which is not the usual academic pathway, but I was just tired of the academic rat race. And I moved to a really nice community hospital in the Detroit area called Providence Hospital, and they let me do whatever I wanted. And it so happened that next year, a good buddy of mine, gave me this book by John Sarno, Dr. Sarno, where he was saying, he's been writing this since the 80s, that a lot of people with back pain, it's not because of their back, it's because of stress and trauma and emotions that are going on in their mind and in their brain. He didn't have all the science and neuroscience to back up what he was saying. And he made a few mistakes along the way, but his general thesis turned out to be right. And he began over years to expand it to other things besides back pain. Anyway, I went to work with him for a few days, and I came back to our hospital, and I said to my boss, hey, I want to start a little practice in this. And he says, okay, go ahead. So I just started talking to people, and I took time, and I literally just started talking to people about their lives and their pain, and looking more and more closely at what are the characteristics of pain that allow us to determine if it's actually a structural pain, as is our first job as a physician or a PT or whatever we are, to make sure that we're not missing some kind of cancer or fracture or inflammatory disease, right? We have to do that. But I also talked to people about their lives and looked at the links. And so one of the very first patients I saw was this lady who had headaches for 17 years. She'd been to several headache clinics. She had injections. She had every medication you could name, and nothing helped her. And she told me her simple story, which was that she got the pain when she got a new pair of glasses, a new prescription. Like, how can that cause pain for 17 years? They tried to fix the prescription, gave her different lenses, whatever, nothing worked. So I said, well, what was your childhood like? She says, well, my mom was fine. My dad was just a little unpredictable. Sometimes he'd come home, he'd be really happy and smiling. Other times he'd come home, he'd be so angry, he'd grab me by my shirt and scream and yell at me, what's wrong with you? Can't you do anything right? And she grew up and she was fine. She had no symptoms until she was in her mid-40s or late 30s, I think. And I said, so what was going on at the time you got the new pair of glasses in your life? She said, well, my husband was fine. My kids were fine. My job was fine. Anything else? Well, my boss, he was a little unpredictable. Sometimes he would be really happy and kind and supportive, and other times he would just go off the rails and yell and scream. And it was really hard on me. And it was like, oh my God, could this be the cause of her pain? That her brain was primed as a child to be so fearful of a particular type of stress or trauma. And when that stress or trauma recurred in her life in a mirror image way, that her brain was trying to send her a message, say, get out of there. Something is wrong. And the brain doesn't speak English. It speaks in pain or anxiety or depression or fatigue or insomnia. And she became fine. No doctor, no headache doctor could help her. But using the simple methods that we can talk about, her headaches completely went away after 17 years of chronic daily headaches. And we see the same thing with back pain and irritable bowel and fibromyalgia and all these disorders that are, and the new ones now, we have Ehlers-Danlos and POTS and mast cell activation syndrome. There's always something new that we're trying to pin down as a structural problem. We can talk about long COVID even if you want. But that just blew my mind. In the last 21 years now, I've been working on it, trying to refine the history, refine the diagnostic methods, and refine our treatments, along with lots of other people in this space, to do better. Now we have randomized controlled trials showing that this stuff works, TSW.
Has definitely been encouraging. We're all looking forward to kind of seeing more and more come out. Obviously, replicating some of the great results is always a challenge, but it definitely one we're hoping to see, methods like this, accomplish. Discuss how it took you this transition of kind of working into what, Dr. Sarno's book really stimulated it. Where do you see like general training of physicians? And this exists obviously in physical therapists where I work. Where's that lacking as far as helping prepare clinicians to enter the world and have the ability to kind of manage these type of cases well? Obviously, we tend to still educate in a more traditional biomedical, very linear pain view of things where structure equals function equals pain type thought process. I'm just wondering where you see the challenges that lie in our training of physicians and healthcare professionals.
I'm working with a great psychologist at University of Michigan now to set up a training program for the medical students at University of Michigan. And we're looking at this model that I've been thinking about. I haven't really written about it too much yet, but I'm thinking about it a lot. And it's the idea that there's three models, ways of thinking about pain. The original model is the biomedical model, the structural model, that all pain is due to an injury, and the brain just reflects what happens in the body. And sometimes that's a fine model to use for certain types of disorders. You have a broken arm, fix the arm. And a lot of patients really want that model because they just want a pill or they want a procedure or whatever it is. And then the second model is the dominant model in the field now, which is the biopsychosocial model. So started by George Engel, who was one of my heroes. I don't know if you can see, there's a picture of Dr. Engel up on the wall on my bookcase up there. And so there's nothing wrong with the biopsychosocial model. It's an incredible model. But what's happened over the years is the biopsychosocial model has been used in great ways, biopsychosocial. We have a little bit of each. And when you apply that to pain, what patients hear is biopsychosocial. And part of what they hear is there's something wrong in the body, and then it's being changed or amplified or processed in the brain and by my social circumstances. And that model works really well for disorders where there is a biological issue, like, say, rheumatoid arthritis, or something where there's an inflammatory condition in the body, and there's processing by the brain, and the immune system gets involved, and you can do work with that. And the dominant treatments for that are in the psychological space, are cognitive behavioral therapy, mindfulness therapies, and acceptance and commitment therapies, which all are great therapies and have a really good track record. But this model is not really a curing model. It's more of a coping model. You've got a problem and we'll help you cope with it. And that's been the dominant model in the field of pain. We'll help you cope with the pain. They're not assessing what the cause of the pain is. It's just saying you have pain and we'll help you downregulate your brain and your nervous system, and that'll help. And the research on the model has shown positive effects, but relatively small effects, and effects that tend to not persist over time. And this is very clear in the thousands of studies that have been done. So it's not a bad model at all. The model that we're using is what's called the symptom perception model, which has to do with the fact that our brain creates what we experience. And this is based on the predictive processing. And this is to answer your question, Mark, this is the part that's missing in our training. The idea, and most people at all levels of training are missing this and not getting this, because the symptom perception model tells us that our brain literally creates what we experience. And the simple way we know that is that we don't see with our eyes. We see with our brain. If you needed your eyes to see, you couldn't see in your sleep when you dream. So obviously the brain can create the images that we see. And the way the brain works is predicting what we see. You know, when you see a bird flying overhead, actually our brain can't process the bird flying or the insect flying. It has to predict ahead of it's going to be to make it smooth, to make it look like it's a smooth path. And whenever you're predicting what's going to happen, you're going to make mistakes. So the brain has to filter out, billions of bits of data all the time and only pay attention to what's salient. And the neuroscientists call that the salience network. And the salience network lets us pay attention to what's really important. If a car swerves toward you on the freeway, your salience network kicks in immediately and you have an immediate reaction. Your brain's always looking out for you. And so with vision, we don't see with our eyes, we see with our brain. And our brain's going to make mistakes. Eyewitness reports of crime are notoriously inaccurate. When a police officer goes to a scene of something, do they see a gun or not? Well, it depends on what their brain sees. What we hear is the same thing, and what we feel is the same. So the simple fact that you can have an injury without any pain, that's simple fact, which has been shown and replicated thousands of times in the literature, means that it's not an injury that causes pain. It's not a one-to-one relationship. It's because the brain decides to create pain at some level. And usually it does it within a nanosecond. And usually when there's an injury, you get pain because the brain's there to try to protect us. And then if you take the opposite, where there's thousands of examples of people who had pain without any injury, such as the simple story, the guy who had the nail through his boot had severe pain, but no injury at all. What does that tell us? And research shows, a lot of great research from UCLA and from the University of Michigan, showing that stress and emotional input to the brain activates the exact same parts of the brain as does a physical injury. And this simple fact tells us that all pain is created in the brain. It's created in the brain either through an injury or through some stress or emotion situation that leads to this danger alarm signal, which produces pain or other alarm symptoms, anxiety, fatigue, etc. And that pain is, of course, 100% real. It's all the same. It's all created by the brain. So it's just as real to have pain that's coming from a broken arm as it is coming from a broken heart. It's just as, and it can be just as severe. And our patients are like, how can my brain produce pain that's so frigging severe and debilitating and lasting for years? How can that possibly be my brain? And the answer is, it happens all the time. We've got new data that we can discuss about back pain and the etiology of that as well. So that's what's missing. And I think those and these different models are really highly useful. They're all useful, but I think they should be applied to the correct disorder with the correct patient. So the patient may not want our symptom perception model, your processing model. They may reject it. A lot of people do. I mean, surprised. Oh, it's in your brain. Are you saying it's all in my head, doctor? F off. We hear that a lot. A lot of your, when you try to explain this to somebody, they're like, yeah, right, doc. I think I need a different doctor or a different PT. But for certain disorders, like headache, migraine, we'll talk about back pain in a minute, fibromyalgia, irritable bowel syndrome, most chronic pelvic pain, where people are diagnosed with pudendal neuralgia, interstitial vulvodynia, coccydynia. Vast majority of those, I would argue from our experience and data, is mind-body pain or neurocircuit pain.
Wondering if you think, because you point out, and I definitely see this clinically, and I'm sure a lot of the people listening see the same thing, of just this rejection of that type of thought process. And I'm wondering if you see in your practice where people almost have to go through a journey before they're ready to accept this type of narrative. And the journey, unfortunately, is a litany of ologists and specialists and massage therapists and physios and chiros and all, we could probably go on listing folks who take that, like, I'm going to find it and fix it type thing, and type of issues. And we'll get into how you kind of evaluate who is that right patient, where it's more that kind of centralized pain like you speak to in some of your work. I'm just wondering, do you feel like that journey just needs to happen for some people, or are there people who are ready to take on that narrative even early on in their journey with persistent pain issues?
Yeah, great question. It's variable. I would say most people need a process, and there's nothing wrong with the process of ruling out medical problems. We want that to happen. Obviously, I'm a physician. I know there's disease in the world, so we want that to happen. But on the other hand, some people can pick it up really easily, because it's not that counterintuitive to recognize that when you have a stressful day, you might get a headache. It's not that counterintuitive to recognize when you're suddenly put on the spot in front of a bunch of people, they have to speak, that your stomach turns into a knot. It's not that unusual to think that when someone's a pain in your neck in your life, that you might get neck pain. I mean, it's not that unusual. Louise Hay sold like millions of books about this, about the symbolic nature of pain. It's not always true or, applicable, but it certainly happens. And so some people can latch onto it quite quickly. And then some people go overboard, They've read Dr. Sarno and they say, oh, all back pain is mind body, or all sciatica is mind body. And clearly that's not true either, because we need to evaluate people. That's just part of the process.
I wonder if we can get into a little bit of the process. We spoke before we started our recording today, and the pain reprocessing therapy, one piece of a more kind of comprehensive nation assessment that you do. One big part of it is making sure it is, the type of pain is being delineated, and not just, again, everything assumed to be centralized pain, and then not everything assumed to be true nociceptive tissue-driven pain. I'm wondering if you can speak to a little bit of the process you go through to kind of take you through this kind of approach.
Yeah, that's really important. And I've spent so much time working on this. And so we published on this, and there's a new study that we just published that I'll tell you about at the end of this little section here. But the bottom line is, of course, job number one, as I said, rule out a structural problem. Get the routine medical tests. Make sure that the studies have been done, number one. Number two, do not overinterpret data. And I'm sure you're well aware of this, and hopefully most of your audience is well aware of this. But we show a slide to all of our patients. Every doctor and every physio and every chiro needs to see this slide, that 80% of 50-year-olds have degenerative disease without any pain, 90% of 60-year-olds. 60% of 40-year-olds have degenerative disc disease with no pain at all. It goes up to 95% as you age without pain. And back pain does not rise with age. It levels off at the 50s or 60 level. And bulging discs are the same. You can see the exact same pattern with the vast majority of people. And even 30% of 30-year-olds have bulging discs without any pain. And so to attribute, and it's the same with facet arthritis, and the other spondylolisthesis, et cetera. So if you overinterpret that and you blithely assume that the pain is due to what's on the MRI, ignoring the data that these findings can be normal, I think that's a disservice to the patient. It's the same thing with small fiber neuropathy and peripheral neuropathy type things. EMGs and nerve conduction velocity studies showing minor changes are normal in a lot of people and shouldn't be overinterpreted. And we know from Creamer's work on x-rays, just plain x-rays, if you have a severe, totally damaged hip, yeah, you probably need a new hip, okay? Obviously, but mild to moderate arthritic changes in shoulders, knees, and joints are normal in a lot of people. Labral tears in shoulders and hips are normal in a lot of people without pain. And there's ample data to show that. So get the good evaluation, rule out a structural problem. Secondly, don't overinterpret tests and have an open mind. Well, if you have an open mind, then you're left with, I don't know, maybe it's your hip, maybe it's not, maybe it's your back, maybe it's not. So what we've developed is the third step of the process, which we call the rule-in process. How do you rule in a neural circuit problem? Well, the way you do that is with the characteristics of the pain. And so I've developed this something called the FIT criteria. Is the pain functional? Is it inconsistent? And is it triggered? And what that means is pain and most people really understand this. It's not rocket science. It's not like I created some magical formula, but I just put it together in ways that are simple and easy to use. Functional pain. If you have sciatic pain in your leg, it's going to be the back of the leg or the side of the leg or the front of the leg, depending on what dermatome it is, right? But if it's the whole leg, well, that's functional. That's not a nerve. No nerve goes to the whole leg. If it's both legs, it's bilateral. You can certainly have pain that's bilateral if you have a central lesion, if you have diabetes or something. But frequently, pain that's bilateral started in one thumb and geez, it went to the other thumb. But the x-rays aren't showing anything much. And it's not rheumatoid arthritis. So what is it? And so you see this bilateral, that's also tends to be functional. You see pain that started without any provocation. It woke me up at night. Well, what's going on at night? Your brain's active at night. Conscious mind is asleep. And it is, so that's the kind of functional. It's in a wide area. It's the whole side of the body, or the whole head, or whatever. And then, of course, certain disorders are functional, like migraine, tension headache, fibromyalgia, irritable bowel. These things, we know we've done evaluation, and there's no actual tissue damage in the body. So that's functional. Inconsistent means the pain turns on and off. So I was talking to a lady the other day. She had severe headache pain. And it just went on and on and on. Doctors couldn't help her. No one could figure it out. She said, I'm going to go to Hawaii. She went to Hawaii. Boom, pain turned off like that. She came home. Boom, pain turned on again. She said, oh, I know what this is. It's not rocket science. It turns off when you go into, it's there when you're sitting in a certain chair, but not there when you're sitting in another chair. And the PTs and the chiros are saying, oh, well, it's the way you're sitting. It's the posture. Oh, that chair was just a little softer. It's like, okay, is that really going to make that much difference? Maybe, I get it. If you're trying to fit it into a structural model, you can always find a way to do that. But if you step back and say, God, it's really turning on and off. Sometimes it's on the right side of the back and other times it's on the left side of the back. Oh, why is that? And we're saying, well, the neural circuits are turning one pain on and turning the other pain off. So that's inconsistent. And then triggered means triggered by innocuous stimuli. Is it worse with light or sound? Is it worse with stress? Is it worse when you go to visit your in-laws? Is it worse with the weather? Is it worse when and then the big one is it worse when you're bending over or twisting? Okay, so if you have back pain and it's worse when you're bending over, well, that sounds structural, obviously. It has to be structural. But if we have an open mind, it could be a conditioned response. It could be that the brain is sensing danger in the movement of bending over, and this happens all the time. How do you sort that out? Well, you have to probe, and you have to listen, and you have to say, well, does it always hurt when you bend over? Sometimes it doesn't, sometimes it doesn't. That's interesting. Why is that? Does a structural problem sometimes there and sometimes not there? If your arm is broken, sometimes it hurts and sometimes it doesn't? I don't think so. And then I've got this other thing, which is really like my pride and joy, testing, which is basically asking if you have pain with bending over, asking people to stand up when they're having light pain or no pain, and ask them to imagine bending over. And you would be amazed how often people say, yeah, I just imagined bending over and, oh, wow, my back started to tighten up. Or I got this tension or anxiety in my chest. Your brain is showing you that it's afraid of bending over. And then you can reverse that in 1 minute, 90% of the time. And it sounds silly, but I just tell people, well, that's interesting. We have all this data that the whole evaluation, it looks like this is a non-structural pain. This is a nociplastic condition that you're dealing with, which is real. You're not crazy. It's not in your head. You're not nuts. It's not because you want the pain. It's not your fault. It's real. This is common. We see this all the time. So what if you tell yourself that you're okay, you're safe, you're not in danger, that there's nothing wrong with your back? What if you just tell yourself that in your mind, and then you imagine bending over? And they go, okay, well, I'll try it. Yeah, sure. I'm safe. I'm not in danger. There's nothing wrong with my back. Now I'm imagining bending over with a smile on my face. And I say, well, what happened this time? Oh, my back didn't tighten up. Holy crap. You just changed a neural circuit in your brain. And now all of a sudden it all becomes clear. This whole evaluation that we did. And then obviously the final thing that I didn't even touch on yet is you can look at, well, what was going on in your life when the pain started? What was your childhood like? And all those sorts of things. And how do you treat yourself? Are you really hard on yourself? Are you really, somebody, it started with, somebody at work didn't, passed you over and gave somebody else promotion. And then you start beating yourself. What did I do wrong? What's wrong with me? Why can't I succeed? And that kind of triggers more of the danger signal in the brain. So that's the model we use. And we studied it just recently. We just published a paper in the Journal of Pain that just came out, I don't know, this year, a couple weeks ago, I guess, where we evaluated 200 people using this model, physiatry practice, unselected, people with chronic neck and back pain, totally unselected, not selected for, oh, you're coming to a research study on stress, or something like that. You're coming to a physiatrist because you have pain. And this physiatrist, who's a fantastic guy named Bill Lowry in Lake Charles, Louisiana, a blue-collar population, not some upper middle class, deal going on down there. And these folks, and he evaluated using the same criteria I just gave to you. And if you have 222 people coming to a regular, usual PM&R practice, like all of his partners in his own practice, 95% of them would be diagnosed as having a structural problem, roughly 90 to 100%, depending on the doctor. His data that he came up with using these criteria was 88% were non-structural. We just published this. It means 12% were either structural or combined. And he says this is cautious. This is a cautious number. This is not a wild. If I think it might be structural, I'm going to put it in the structural category. And there were some that he thought were structural that we put in the structural category that future data showed him it was actually non-structural. But we didn't change the category for the purpose of the study. We wanted to keep it conservative. And this, I don't know, to me, Mark, this is just revolutionary data, to have a real data showing this. People have written about this for years. In the Lancet articles on chronic back pain published a couple of years ago, they say 90% of low back pain is non-specific. Well, what does non-specific mean? What we're doing is we're taking non-specific, which means I don't know, and we're taking it out of the biopsychosocial model where it's some bio, some psycho, some social. We'll do a little bit of everything, which shows effect, but not long-lasting and curative effect. And we're putting those people, not everybody, but those people, the 88%, into the symptom perception model, the predictive processing model, the nociplastic category. And when you actually have a nociplastic problem, when you actually know that there's nothing wrong with your back, and I have a good story to tell you about that, my own personal story with my foot pain, I can tell you in a minute. Once you know, it can make all the difference in the world. And our techniques, the pain reprocessing, the emotional awareness, the how we treat ourselves, the changes in your life, those treatments are designed to not to manage the pain or reduce the pain. They're designed to eliminate the pain. And that's what people want. People don't want their pain to be managed, really, right? You go to the main pain centers in the country, right? And I'm not going to name names, but the biggest pain centers in the country, and you get a pain management program, which is based on the biopsychosocial model. We'll do some of the physical, we'll do some of the mental, we'll do some of the acupuncture and the massage and all. We'll put it all together and we'll manage your pain. We can't cure it, but we'll manage it. We think there's a better model for the people who are willing to engage in that model, not everybody, and the people who have the disorder that fits that model, not everybody. But I would argue it's the majority of people with chronic pain.
Study you mentioned is obviously, like you said, pretty eye-opening data that you see there. 88% not having structural pain yet. I would probably venture a guess that 100% of them went into that setting thinking they had a structural thing. So there lies the problem of like, how do you transition these folks to understanding that there's more to pain than structure? We've already touched upon that a bit. I would like to get into a little bit about the emotional piece that you kind of work with your approach. I think that's one thing that I know for me personally, and talking to clinicians, it's not a comfortable area to delve into when anger and tears are shed in rooms. Sometimes I used to just go the other way. I didn't know how to process it personally, because it was just, you get to get comfortable in some of these contexts with patients and kind of getting in the mud with them. But speak to a little bit about, I know there's parts of it where you do expressive writing and emotional disclosure. You also do your emotional awareness and expression therapy as part of it. You don't maybe have to get into the exact, details of it, but can you speak to kind of how it's into your approach?
Yeah, absolutely. Well, the PRT part, the pain reprocessing part, has been shown to be highly effective for eliminating pain in the majority of people in our Boulder back pain study. And we are doing 2 more PRT studies this year in addition to that. So, and there's another study out of Harvard that showed, again, 66% roughly had eliminated pain. Using the PRT approach, which is basically making the pain less dangerous. When you start bending over, you're saying, I'm okay. When you start walking, when you start moving. So your neurons that fire together, wire together. And so when every time you move and bend with back pain, every time you eat something because it's going to bother your stomach, or every time with your headaches, every time, something, some trigger, the weather changes, you're afraid. And you're teaching your brain and reinforcing over and over and over again this pain spiral of pain, fear, pain. And so we reverse that in PRT by helping people be more empowered, less afraid. And sometimes it's hard to do, obviously. How do you make yourself not afraid of pain? Not easy, but gradually over time, we teach them how to change the neural circuits in their brain by pairing empowerment and safety and even joy with movement. As opposed to fear with movement. And that changes the neural circuits. And those can change on a dime. The whole basis of neural circuit, the pain turns on and off. Well, it's turning on and off. It went away when you were in Hawaii. It went away, when you were on the boat with your buddies. It means it can go away. There's hope. There's optimism. So the PRT part is basically that. Now, the emotional awareness and expression part is a little bit more sticky. And, one of the physical therapists, the main physical therapist that I work closely with is Charlie Merrill in Boulder, Colorado. And he and I teach on this specifically for PTs and chiros and massage therapists, any kind of manual bodywork folks, etc. And Charlie has become comfortable dealing with emotions to some degree. Over time, you gradually train yourself. Like somebody says, what do you notice? Here's another thing, what do you notice when you think about that colleague at work who's tormenting you? Close your eyes and just put yourself in that position of of being in a work situation. What do you notice? Again, same thing. I get tension in my chest. I get tightness in my back. Okay, well, yeah. So what would you like to say to that person? Not what you could say or would say or should say. What would you like to say to that person? What's the urge? You've got anger toward them, right? What's the impulse? So simple, right? And you can write it out, or you can do it in your mind. And what would you want to do to them? what would the anger want to do? You would never do this. We don't condone violence. But what would the anger want to do? Oh, that's easy. I want to say to him, F off. I want to say to him, you're a fucking piece of this, and you're worthless. I'm not putting up with you anymore. And I just want to shake him, or I just want to slap him or push him and walk away. How does that feel? Man, that feels good. Now let it go. Just let it go. If you're hanging on to anger, what's that doing to your brain? Danger. What's that doing to your back? Tight. And we have good research showing that that this actually causes. There's a great study by John Burns in Chicago where he showed that when people wrote about their anger, their back muscles literally tightened up. So here's this. How simple is that, right? You can do it in writing. You can do it in your imagination. Now let it go. Okay. And now, is there any hurt? Is there any sadness? Okay. It's sad. It's sad for you that your boss can't see your value. That's sad. What do you do with sadness? Anger is to protect, to defend yourself. Sadness is to connect. So what do you do with the sadness? You turn it into compassion for yourself. I'm okay. I'll be all right. I can handle it. I'll move on. Maybe I'll look for another job. Maybe I'll just do my job and, not worry about the a-hole other person, and, things will work out. I'll be okay. And what do you need to do? Maybe you do need to look for a job. Maybe you do need to say something publicly to your boss about that person, or you need to say something to that person, but you're not gonna punch him, and you're not gonna swear at him. You're not gonna do that. You've already done that. Now you're gonna approach him with civility, but standing up for yourself, being assertive. And this works in marriages, and it works in families, where people need to be able to be civil, but assertive and loving to the people they're helping to realize it hurts when you say that stuff. I care about you. I love you. It hurts when you say that stuff to me. I'd really appreciate if we could find other ways to deal with this. In that process, that's the essence of EAET right there. And it's not that complicated. And we've written about it. We have manuals on it. And I don't know. Do you think, you're a physio kind of guy, right? Does that sound that scary to you, to just what I described? Does that sound doable?
No, it doesn't sound scary. I think sometimes, and I'd be curious to your thoughts too, is just clinicians sometimes feel like they got to paint themselves into this box as I'm a physical therapist, where, and into the emotions and the muddy gray areas of pain is just an uncomfortable thing. And I spoke to this to other guests too, is like, I just think sometimes it's a security blanket for us to hold on to, of just like, I want to resolve it all to this linear pathway, because that's what can give somebody comfort in the clinic. But yet when we see people come in with these complex pain states and a lot of emotions and things like that, I mean, we do them a significant disservice by not engaging with some of these emotions and different things like that. And as you mentioned, I mean, it's something you can have some conversations with people. Do you ever feel like that's a challenge for some, and maybe physicians as well? But I know I've seen it in physical therapists where, like, I'm not a psychologist. Why am I going to be doing this stuff? I'm crossing scope of practice barriers here, and this is something I shouldn't be doing. Thoughts fall on that?
Absolutely. There's no doubt about that. People are afraid. They're afraid of getting sued. They're afraid of scope of practice. They're afraid it takes too much time. Absolutely. But what are you going to do? What are you going to do? You're going to just ignore that when you know that's the thing that could turn off the pain like that, and your patient or client would be eternally grateful to you? What are you going to do? Maybe you dabble a little, or maybe you find a therapist that can work with you. That's awesome, right? Obviously, not all. The role of the medical people can be to diagnose, and the role of mental health people can be to treat using these models. That's a great model. It's just not everybody has that or can develop that or whatever. But certainly, if someone, somebody like you falls on the way of saying, look, I just can't get into that, I'm like, fine, I have no problem with that. Do your good assessment. Use your fit criteria. Assess them clearly and confidently, and tell them and explain to them in loving terms that their pain is real, they're not crazy, and it's their brain that's producing it, and they can have complete recovery. Do that. If you can do that, huge service. huge service to your patients. And if they don't buy into it, fine, you can keep doing the man. You say, fine, let's do more physical therapy. You've already had 3 courses. Well, we'll do 4. Or, maybe there's some injections you want. Say, oh, no, I don't want to do it. There's other medication. There's always options, right? But at some point, they might have heard you. They might have heard that. And at some point, they may want to come back to that because, as you said earlier, there's a process, there's a journey that they go through, then they're not ready to really hear this. And that's fine. They're the ones in charge of their lives. We never force this on anybody. But if you do that service to them and you can find somebody, and there's lots of people virtually, and that doesn't have to be in your community virtually, that we have a professional organization, nonprofit, the Psychophysiologic Disorders Association, ppdassociation.org, and there's a website. And on our website, there's a list of practitioners all around the world who can do this work. And so there's therapists and coaches even who can help people through this process once the person has come to the diagnosis of a nociplastic or a symptom perception or a neural circuit or a mind-body situation or condition.
Only the resources, thankfully, are growing out there, and I think hopefully we see more and more resources out there. I'm wondering if we could speak to a little bit of what you see as the kind of healthcare system challenges that we face to kind of incorporate such a model of care. Reading some of your work, you're able to take a 2-hour assessment and really dive in deep with somebody and do things. Yet you'll have clinicians saying, well, 15 minutes, I have like 30 minutes. I mean, what do you see as is that something where there's just, the person's just got to find somebody who's got time to listen and can sit down and have a face-to-face, human conversation, curious, caring conversation? Or where do you see that challenge as far as incorporating this type of work?
Huge issue. And so if you're the kind of practitioner who wants to get into this with a certain patient, then book a half an hour at the end of the day or 45 minutes at the end of the day where you can sit down and talk with them. But if you're the kind of person who really doesn't want to do that and it doesn't make sense, you might try it with a few people. You might love it. It's so much fun. It's so enjoyable to have that interaction with people face to face, eye to eye. You come up with stuff and they go, oh my God, that's amazing. Thank you so much. It's just so gratifying because burnout occurs when you're seeing people for 10 or 15 minutes and you don't have the time and it's frustrating. This is actually a cure for burnout, in my humble opinion. But anyway, so that's one option, to do that with selected patients. But how do you find those selected patients? What you do in your 15 minutes is you do your assessment and you explain it, 1 minute about, we've seen a lot of people who've recovered completely by doing this brain-based model. And you might be interested, and maybe you're not. Here are some resources. Take a look. For example, on my website, there's a link to 6 cartoon videos, animated videos that explain predictive processing. They're 5 to 6 minutes each. You can take a look at some videos. You look at YouTube all the time. Take a look at these videos. See if they make sense to you. If you want to read something, here's a book, or here's an article, or here's some other videos. And all these are available to help your patients to get a sense, and then they fall into, that resonates. That sounds like me. I mean, I have so many people who've read my book and say, I see myself on every page. I can't believe it. I never heard about this. Or I had a woman who's a doctor, physician. I have several physicians who had chronic pain and had to retire from working, had to stop working because their pain in their arms or their back or their head was so severe. And they came to one of these websites. There's a bunch of them. Mine is not the only one. And after 5 minutes of reading it, they said, oh my God, now I know what's wrong with me. They've been to so many doctors and other caregivers that once the model is there, sometimes people go, that's it, I can't believe it. And then they're ready to do that work. So just a referral for resources can be a huge thing. If they don't want it, they say, no, that's ridiculous. That doesn't make any sense. Fine. We got lots of other treatments you can try. And if they don't work, you can always come back to this next year.
Some of the physicians with chronic pain, I think sometimes that can be the hardest population to switch. I mean, obviously, it sounds like they had been through enough to where they were ready to take on board. But I think sometimes physicians, and then similar with some physical therapists who are still kind of ingrained in that like biomedical view of things, it can sometimes be a hard switch to make. I've worked with a few surgeons, especially, tend to see things very mechanically and structurally based. But when they open the eyes to like, wow, okay, that makes a lot of sense. It can be obviously transformational for a lot of those folks.
This is a life and death issue, literally a life and death issue. You're going to live it's not living when you're living in severe chronic pain. That's not a life. I heard a story the other day with some guy his best friend is a doctor, best friend since childhood, and the guy I know was trying to explain to him that his pain, he should at least look into the mind-body approach. And the guy refused. The guy ended up committing suicide because of the chronic pain. So sad.
Those tragic stories, and yeah, you're right. It is life and death, and you see a lot of people where dramatically shrunk, where it is only pain and nothing more. And having some of these approaches can be pointed out very transformational for a lot of people. So I want to respect your time today, Howard. Greatly appreciate it. As we wrap things up today, I'm wondering maybe if you can give us an idea of, like, you've already alluded to a little bit of some of the coming studies that you're working with, but I'm wondering, kind of see the future of this type of approach moving towards, and then maybe if clinicians are looking to kind of gain some skills in this approach, where they can look for it.
Yeah. Well, research-wise, there's the 2 PRT, pain reprocessing therapy studies that are ongoing now, one in Boulder, one in Denver. The one in Denver is at the VA hospital. There's 2 emotional awareness and expression therapies going on now, one at UCLA, Brandon Yarn's head of it, and one in Chicago and Detroit that I'm working with Mark Lumley, who's the incredible psychologist that I work closely with, and he and I helped develop EAET together. All these studies are NIH or federally funded, level, well controlled. They're all randomized controlled trials, all comparing musculoskeletal pain to like our EAET study versus CBT versus ACT. So we'll see, are they all the same or treatment as usual? One head investigator says, look, they're all the same. One's not going to be better than another. We've got several. We've already got 2 semi-large, pretty large studies actually of EAET versus CBT showing EAET actually was better. That data's there. So we'll see in this new study. We'll see. Science, the data shows. Well, there's a long COVID study starting at Harvard and another back pain study started at Harvard with Mike Danino. So, and the Boulder and the Colorado studies are with Yoni Ashar. So really high level, good, solid researchers. In terms of training, we've got an mobile app called OvaDX. We've got a full course called Freedom from Chronic Pain, 8 course. It covers PRT, AAT, and the whole shebang. We've got the PRT training courses in Los Angeles, run by Alan Gordon's group, the Pain Reprocessing Therapy Institute, I think it's called. Great people. We've got the EAT training course that Mark Lumley and I run, and then the PT course, the Beyond Pain Management course. And so many PTs have now been trained by Lorimer Moses, who's one of my heroes, right? Who has really done a tremendous amount to advance the field of pain, and the studies he's done are amazing. But what he's finding is that education alone isn't enough. And that's why the work of Peter O'Sullivan that you've had on your podcast, his work takes it to the person, which helps them see in their body. See, PTs can be such an amazing resource because they're working with people in their bodies, and they can, instead of saying, geez, you've worked on your abs for so long, they need to be even stronger, as opposed to saying like, wow, when you move, you're okay, you're safe. Let's have you move with joy. Let's just have you move your arm. Let's have you move your back with calm and peace and safety. Your back's okay. I've evaluated it. You've done all the work. Now we can click your brain in to teach your brain that your back is safe. And now when you bend over, it's going to be fine. And you're telling yourself you're okay. Practice that. Walk a little bit with joy, 5 steps, and then walk 10 steps with joy. You guys can do that. And it's amazing. So our course that Charlie Merrill and I run, is just perfectly designed to take it, what we consider, and I'm not missing Lorimer. I love Lorimer. He's a hero of mine. To take it to the next level beyond the pain education, beyond the CBT and ACT type stuff, to the level of PR. And I'm only saying this because the data, that's what the data is showing us. And we'll follow the data, and we'll see. But I'm so excited about this revolution in pain management, this revolution in pain reversal.
I think you speak to some of the issues with, the Traeger study where it showed that pain education on its own. Lorimer was involved in that study. It was he had published about it and wrote about how it was kind of a disappointment of his, but then we're approaches like CFT, PRT, and the approaches you spoke to today, where it's taken it that next step of like, hey, it's a piece of the puzzle, but we need to go further. And it's great to see methods like yours starting to take hold and take it that next step and seeing some encouraging results that we hope to see more of in the future. We'll link more of the trainings that Howard mentioned in the show notes. So if anybody's interested, you can definitely go in there and check it out. We'll also link some of the articles that were referenced today in the show notes. I'm going to leave it at that today, Howard. Again, thank you so much for your time, and thank you so much for the great work you're doing to help us better manage folks in pain.
It's a privilege and an honor. I really appreciate what you're doing to get all these diverse and important messages out to a community of people who are on the front lines and need help, because it's hard. It's hard work.
It is hard work, but as you mentioned, so rewarding work. And again, those of you listening, really appreciate you listening. If you can subscribe on wherever you're listening to your podcast, and then if you're watching on YouTube, if you can subscribe on YouTube, we greatly appreciate it, so we can spread this message to more people, be it a clinician or maybe it's a person struggling with pain who comes across this and changes their journey. So thank you for listening. That's all for this week. We'll talk to you all next week.